Good afternoon, and welcome to today's program titled An Ounce of Prevention, Strategic Planning with Confidence in Uncertain Times. I'm Tom Valentino, Senior Editor of Behavioral Healthcare Executive. Today's program is sponsored by the Echo Group. Thank you to our sponsor and to our audience for giving us your time and attention today. Before we get started, we have a few housekeeping details. Please use the Q&A box below the slides to submit a question or technical issue at any time. You do not have to wait until the end of the presentation. To download a copy of today's presentation, please click the link in the resources area to the right of the slides. And finally, for those of you who tweet, please tweet along with us using today's hashtag BHELiveWebinar. At this time, it's my pleasure to introduce our speakers. Candace Clevenger has been employed with Heritage Behavioral Health Center for the past 26 years and currently serves as Chief Executive Officer. In her previous role as Chief Financial Officer, Candy provided oversight of the business, human resources, building operations, and IT functions of the organization. Tim Mackin has been employed with Heritage Behavioral Health Center for the past 21 years and currently serves as the organization's Chief Operating Officer. In this capacity, Tim provides oversight and guidance to Heritage's clinical operations with a more specific focus on mental health and substance use outpatient medical services. Mary McClyman has been employed with Heritage Behavioral Health Center for the past 20 years and currently serves as Chief Administrative Officer. Mary plays a pivotal role in the design, development, and implementation of Heritage's EHR from the billing as well as the clinical features of the record. Thank you, Mary, Tim, and Candace, for taking the time to speak with us today. And with that, the audience is yours.
Good afternoon. This is Tim Mackin. So I'm sure, much like all of you, when we get into the idea of strategic planning, we're in a very different time, and the pace of things is drastically different. So before I get started on some of that, I want to at least give a kind of a brief introduction as to who we are and where we are and what we do. Heritage Behavioral Health Center is in Macon County, in pretty much the dead center of the state of Illinois. So that graphic kind of, if you look at the graphic, you'll see we're right there. We have about 200 employees. We've been at that level for some time. And we serve about 6,000 individuals a year in our various clinical service programs. We have an annual budget of about $10 million, and we've been operating for just over 60 years. We celebrated our 60th anniversary this last fall. The screen also kind of gives you a sense of our service mix. In the top pie chart that you look at, if you look at about 50% of what we do is classified under care coordination for us. It's kind of a combination of case management and community support, which is a significant portion of the services provided predominantly to our folks experiencing significant mental health challenges. If you then look at the bottom pie chart, it's kind of interesting for us because this has changed. So prior to the Affordable Care Act and Medicaid expansion, and Illinois is a Medicaid expansion state, we went from having less than 70% of the people we serve having Medicaid to now being greater than 90% of the individuals having Medicaid. That's a big jump for us. The next screen, as you're seeing now, focuses on kind of the primary diagnoses of the folks we serve. And again, the top pie chart is kind of significant for us in that it's been a significant change in the last 3 years. As you're aware, and we'll be talking a little bit more about this with the national opioid epidemic, we are now at about an equal distribution of people with opioid disorders and alcohol use disorders, and it's about 66% of the population we're serving in addiction treatment. That's a big shift from 3.5, 4 years ago, where the predominant drug of choice of people coming in was cocaine and alcohol. Alcohol has been kind of a constant. When it comes to the mental health diagnoses, primary diagnoses in the bottom pie chart, you can see that the largest section of that pie is depressive disorders, and then combined with the psychotic disorders being the second largest group, and then a multitude of others that we serve. So Heritage has kind of moved away from a traditional multi-year strategic planning process. The pace of change that we're all experiencing is such that predicting or planning beyond 12 months is difficult, if not impossible, and it just has not done well for us. To do this, though, and for us to move to strategic planning being a ongoing process that is kind of more of a function of day-to-day operations, we have to do some key things. And for us, that requires that we're continuously seeking and maintaining our knowledge as to what's going on at a local, state, and national level. We do this in a lot of ways, but predominantly we're active participants with National Council, with our State Trade Association. We always have folks going to Open Minds as being one of the conferences where you are definitely getting what's going on nationally, current information, and it's been very beneficial to us. And then locally, our staff, our leadership staff, are actively involved in going to the various human service consortiums and groups in town, and as well as attending civic organizations to not only market and get the word out that who we are and what we do, but also to get input from various other folks in the community. This slide kind of says it all for us, the response to rapid change. There's a lot of things going on out there, as you all know, and this just kind of gives you a sense of that kind of chaos that we're all kind of experiencing. Risks, and I was going to be dramatic saying this, so it's risks and threats and challenges. Oh my. There's a lot of them out there, and as you look at these are ones that most of us are probably experiencing right now. But we have the privilege of being in the state of Illinois, and the distinction of being in the state of Illinois, which is now heading into its third year of having no state budget. So I would say that the state government in Illinois is not a good example of effective leadership and appropriate and effective strategic planning. As a matter of fact, that variable alone is making strategic planning very difficult when it comes to just budgeting and planning for each year. As you look at some of these risks, some of them, and I'll make note of the last one, like national labor issues. One of the ones that we were really trying to get ahead of the curve on and planning for was the change in the difference between exempt and non-exempt staff, and the change in what salary requirements to make somebody qualified to be an exempt employee. And that's been on hold now, been put on hold by the new administration in Washington. But it's still hanging on out there, so it's still there. So there are other issues that are happening related to that. I know whether it's federal or states looking at minimum wage laws and that kind of stuff, stuff that can affect you clearly, and those are potential threats to the organization. So we're going to get into some things to consider. And these are things as you're going through this, and we're going through the presentation, things for you to be thinking about as we do strategic planning on an ongoing day-to-day basis, as we do what we do. These are the things that we're thinking about. These are the things that we consider. So looking at, do you have an informed, supportive, and open-minded board of directors committed to your mission? And we're going to talk more about the board in a second. Do you have a strong management team that's nimble enough to respond to the rapid changes in the industry with the ability to respond? And do you have the right staff to help the organization achieve its mission? How does your organization measure quality care? You have access to data, and you're going to hear us use the term actionable data, but it's not just having information or data. It's data that you can actually use to help you make decisions and take calculated risks. And do you have the cash and resources to weather the storm? And that storm is the potential growth, the potential loss of revenues, other things that could definitely impact you. Are you prepared for potential growth opportunities? Potential growth opportunities, and we'll talk a bit more about that at this point. We always think in terms of the threats that are out there, looking at threats to actually reducing income or reducing revenues. But there's also the opportunity that can come with some of these risks, and are you prepared to deal with the potential growth that's there? I'll give you a quick example. So this last July, we had the unfortunate experience of not foreseeing the departure of 6 outpatient clinicians, licensed clinicians. We should have seen some of this coming. We've always kind of experienced turnover in outpatient, but we never had 6 individuals leave within the same 30-day period of time. We knew that there was a national effort. There was a organization our state and Department of Corrections was contracting with. We knew when we were at National Council in Washington a couple of years back, and they were actually trying to recruit our staff then. But it just came to fruition this last July, and all of a sudden, because they made offers our staff couldn't refuse, in some cases doubling their salary. But we had not been prepared for that, and we looking back at that, we knew competitive salary-wise that's something we probably should have been addressing. But what we didn't anticipate then, within that same this current fiscal year in January, we saw a doubling of the number of people walking in to our open access system. So our challenges at recruiting staff to fill those vacancies and then doubling the number of people coming in put a significant challenge before us. It's something we had to do something about. We'll talk more about that a little bit later. Also, we, over the last 3.5 years, we're definitely experiencing the increase in the number of people presenting with opioid addiction. We did, based on that, make a very good decision, I believe, in that we were able to respond quickly. We had then added a self-pay component to our opioid treatment program, our medication-assisted program, and we actually were able to triple the size of our methadone program in a short period of time. And that really meant to meet that need, and we even have more potential growth coming with that as the state Medicaid plan amendment process continues and gets approved, where Medicaid will start to pay for a Medicaid case rate for our methadone program. So we already know we're preparing for that now. We know we're going to need more staff. We've been able to react to the issue that we faced with the staff shortage. We were able to, over the last several months, do research and come to a new pay scale for our outpatient staff, and I'm happy to say we've filled all of our vacancies, and now we're continuing to interview to exceed the previous capacity we had before. So we are moving forward there. So as I said before, I was going to touch on some of the other things to consider, and the board of directors is one that's kind of crucial. The reality of it is, we're at a point in history where it's really important that you consider who you're putting on the board of directors. You really need individuals that are forward-thinking, that there's a willingness to take risk, the connectedness to the community. Are they business-minded? Are they passionate about the people you're serving? And do they have the ability to fundraise? One of the things I will say with boards that's crucial is you're not just filling a vacant seat. It's not just a friend of another board member who's interested because they know somebody, but it really becomes a strategic issue for you in that if you don't pick the right board members, at the very least you could have a poor functioning board. In the worst case scenario, you can get a board where you may have some toxic problems going on. So it really is crucial that you try to identify and recruit good board members. This kind of goes without saying, but you obviously, in strategic planning and for the health and strength of your organization, need a strong management team. Obviously sharing mission. Are they innovative? Do they value and respect each other? Are they open-minded and creative? Do they have the ability to think outside the box? One of the things that we strongly believe is that, and this is something that we've had discussions with other sister organizations in the country, that we believe ultimately you're only going to be able to go as far as your middle managers take you. You can have really strong executive leadership, you can have a great board, but if you have really ineffective middle managers, things will not move forward, and you'll be stuck. So it's kind of crucial. It's kind of the good to great idea that you got to look at who's on your bus, who needs to get off the bus, and who do you need to put on that bus that's going to help you get to where you've got to go. Obviously, you want people that have good, solid problem-solving skills, that they can see the big picture, and that we want them contributing their thoughts and ideas beyond just the silo of their own programs or section of the organization. Is there an awareness of the market forces? And again, this gets back to staff training. This gets back to the idea of having your eyes and ears and aware of what's going on locally, nationally, and in the state. until they have a safe environment to express their thoughts and opinions. And that, believe it or not, these ideas take some work. We committed to that several years ago. We actually had a need to help improve the ability of the management team to work more effectively together. And we actually took a several-day workshop on leading from within that really made a significant difference with our leadership and management team. Investing in employees. Talking about investment in employees, and we'll talk about return on investment. But as we talk about strategic planning and having your organization be in a position where you can do the things you need to do and respond quickly, are you investing in your staff? So from a salary standpoint, are you providing competitive salaries or offering those? Are you hiring the right staff who have the right stuff? You have subject experts, you have people that have specific knowledge, but more importantly than ever for us, it's hiring people with the right attitude and mindset, that they're willing to be in this for the right reasons and are willing to learn and go with the organization's mission. And again, investing in employees, training, having flexibility as it relates possibly, to scheduling, how they can do their job, and can we have flexibility built into that for them. Our staff, talking about salaries and fringe benefits, actually sending our staff to conferences, whether it's locally throughout the state or even nationally, is an investment in our employees, and our employees actually have viewed that as a perk, and it's a greatly appreciated thing, and we budget accordingly for that. And we do invest in staff training, and then that's in addition to anything we do internally or with online web-based learning. Work-life balance is something we're all hearing a lot about more and more, and this isn't just a millennial thing. It's important to everybody. But the key for us here, I think, is that you have the right people who find satisfaction in what they're doing. Are they making a difference? Are they seeing the outcomes they need? These are all protective factors from burnout, and we want staff to not live to work, but work to live. Vice versa, sorry. We don't want to, I always get that messed up. It's important that we're not living to work and that we are able to actually enjoy our life and have that balance. And do employees get that sense here? Provision of technology. Our staff have access to technology, a commitment to technology, whether it's cell phones and laptops in the hands of our outreach-based staff to what they have internally in the office to get the job done and done efficiently. And then, and obviously the work environment, kind of talked a little bit about that, but growing your own. We've got several examples. We've got 2 chief officers now that came into this organization at entry-level positions and who've made it to the rank of executive of chief officers. So there has been great opportunity for staff here who demonstrate those qualities and skills that can get them there. But it's also investing in people who can become better clinicians, who can become better case managers, so that there's opportunity for vertical and horizontal growth. I'm going to shift gears a little bit, and one of the key things is we do our kind of this rapid day-to-day strategic planning process. We've got some elements of how we do things and processes that help us to do that. I'm going to talk about wrap-up because it's one of those key components to our ability to do that. Our wrap-up is an end-of-the-day 30-minute meeting. It's typically attended by predominantly all of our clinical leaders, and then we have some folks from IT and support that come and contribute to that process as well. This is the time of day when staff are typically cleaning up, getting ready to prepare to leave for the day. It is based upon the use of our electronic health record, and I can't say it enough, and Mary will talk about this in a little bit, but the technology is kind of the crucial key to this as we look at having actionable data to look at. So it's a major utilization review, utilization management meeting. We are looking at things that are key indicators of quality. We're looking at mitigating our risk. We're looking at how it affects us from an income standpoint with authorizations for services and that kind of thing. The thing that it does for us that we've found so beneficial, that we are able to address concerns on a daily basis. That's clinical concerns. It's anything related to how things are operating day to day. We process treatment requests. It provides an opportunity for clinical leaders to actually get on the same page and communicate. A few years back, we had a staff satisfaction survey that, and this would not be a shock to most of you because it probably comes up in most agencies' staff satisfaction surveys, but communication comes up as an issue for a lot of staff. And of course, we automatically assume in our roles here, we assume that was meaning vertical communication, that there was a top-down, bottom-up issue. And we ultimately pulled together a focus group. In that focus group, what we found was there was actually communication between programs and how those programs were working together. And it was really surprising to us. So with programs and having all the clinical leaders present, we're able to problem solve and deal with a lot of these issues that are coming up on a day-to-day basis based on what the data is telling us. And it's improved those relationships and communication. It's improving our staff morale and rapport. We've had definite improved outcomes and improved customer service within that. There's a lot of bullet points here, but these are all things. And you have to keep in mind that this is happening in the space of about 30 minutes. Sometimes we may go a little longer, and sometimes we go a little shorter because we also use this as an opportunity to staff cases, problem cases, difficult cases, and that kind of thing. So it really is a very very functional team that has a lot of things going on, but it really is efficient, and it happens in a rather short period of time. Results of this also have benefited us from increased reimbursements, definitely staff growth and the knowledge of how other programs and how things are working. And one of the things that we have really, really appreciated about this is it has definitely increased accountability. All the clinical leaders being there, their data is out there for everybody to see, and they really don't want to be in that meeting if their data is not looking good. So it has increased accountability, and it's increased their desire to actually make sure that data is going to look good by the time they get to that meeting. This is a major utilization review, utilization management function for us. It helps us tremendously with compliance. But more importantly, I think, as it relates to strategic planning, we are seeing trends developing from day to day. So there may be an issue we deal with today, but if we see the same issue repeatedly showing itself, we know that we may need to bump that up into our system, our council system, our cross-functional work team system. So if we don't get it resolved immediately, it may need to get bounced to our clinical council, or if it's something that needs to go to leadership council, or it could even ultimately end up with our executive team. But the idea is we have over 15 reports we're looking at during this half-hour period of time. And in those 15 reports, it is giving us actionable, usable data, which is crucial to day-to-day and ongoing strategic planning. One of the things I want to mention, and it gets back to the return on investment, I mentioned our expansion of methadone in our medication-assisted treatment program, and how has the return on investment been with that? As I indicated, we actually were able to triple the size of our program. We also then were able to, through a strategic alliance with a local FQHC with whom we've collaborated with for years, we're able to actually create a co-located site where we were providing all of the different various medications available for medication-assisted treatment, and we actually moved our operation and our outpatient addiction services to this site to further expand that. The thing that's been able to do then, if I look at value and cost, the initial expansion of that program, and we almost triple the size of the program, is we had minimal increase in expenses at that point. We may have had to purchase more medication from the distributor, but we didn't necessarily have to add staff or other additional leadership. And as a result, that was able to generate revenue that we could actually help accomplish and meet other demands within our system and to work on our mission. It was a triple win in that it clearly helped us focus and achieve our mission of trying to get to the folks that needed us the most. It was a definite win for the people that needed that treatment as they were able to get better control of their lives and enter recovery. And a big part of this was to help prevent overdose deaths, which has been tremendous. and then really for us was the ability to generate revenue that can help us, again, continue to grow the programs. And as I mentioned, open access, the return on investment there, it's too early to tell, but as we've added the staff, we've refilled the vacancies, and we're growing in preparation for future growth. That investment has been a good one. So as you can see on this return on investment slide, we've talked about these, investing in staff training, the various different types of trainings we offer. I do want to touch on interns, and this is an example, again, of us constantly looking at what we're doing and how we might want to change our focus and our philosophy on this. We have been limited historically to the number of interns we could take based upon the number of licensed clinicians who had the capacity to provide adequate and really good supervision to them to make an internship experience worth their while. We're now looking at this as maybe from an investment standpoint, getting good interns in does a couple of things for us. It provides staff who actually can provide billable services for which we can increase revenues, but it also helps us create a stronger pool of possible applicants to fill vacancies as they come up. And one of the universities we've had a relationship with, we've over the years had a pretty good success rate, at least for a couple of years post-graduation, getting new employees from those coming from those internship pools. So the change and shift for us is perhaps we should be investing in doing more of that by having a person who can supervise a large number of interns, where the revenue can pay for that position and it further increase our applicant pool and train the future staff for our organization. Facilities are kind of always a crucial thing. Do you have the space? Do you have the facilities that are attractive and comfortable for where people want to come to services? It's something you have to be thinking about. You know, we co-located, expanded the space we have, and we need to expand it further. We are running out of space to put more staff. So those are things you have to consider. Technology, and I'm going to turn this over to Mary, but technology becomes a foundational piece of this process of strategic planning. And without the technology, we wouldn't have the data at our fingertips and at the speed we can get it if we didn't have that technology. So I'm going to turn this over to Mary McClyman. Thank you.
Thank you, Tim. Let me start by saying without our electronic record and billing software, we would not be able to achieve many of the strategic goals Tim has shared. Heritage started our journey to find an electronic health record in the mid-90s. After many product demos, consultations, and internal meetings, we found a record that we felt would meet our needs at the time and have been with this company for nearly 20 years. I would like to spend a few minutes sharing with you our experience with our record and pose some questions that you should ask yourself about your current record, or questions you should ask or get answered prior to purchasing a new electronic record. Is your electronic health record meeting your needs? AKA, do you like your record? I hear that question oftentimes when I'm out and about and everybody wants to know, do you like your record? While every product has its pros and cons, your electronic health record must meet the majority of your clinical and financial needs today and in the future. We have found a solution that works for us and one that we feel confident will move us into the future. I hear a lot of people complain about their software company. We spent a lot of years talking about what our software could not do before recognizing some of our limitations were in our own IT department. If you have a solid IT department and you still are unhappy with your electronic record, I would suggest you look at alternatives. There are good records out there, and having one that meets your needs is imperative to your survival in our rapidly changing industry. What kind of relationship do you have with your software company? Is support easy to work with and responsive to your request? Electronic health records come with a hefty price tag and high annual maintenance fees. You are their customer, and you deserve excellent support. Does your software company encourage customers to share information and ideas with each other? Some of our best ideas have come from other customers using the product? Does your software company take time to listen to your ideas for improving their product? Do you have IT staff with the expertise to optimize all aspects of your electronic health record? A number of years ago, Heritage made the decision to outsource a portion of our IT department. The company we use is responsible for the majority of our network management. This has allowed our staff more time to focus on our electronic record. Our on-site IT staff are responsible for designing screens, monitoring data integrity, writing reports, writing SQL scripts, triggers, stored procedures, and so on. We also have a unique situation at Heritage where our IT director started out working in case management and then moved into a supervisory role in our billing department before moving into his current role as director of IT. We are fortunate to have someone with end-user experience that also has the aptitude to learn the ins and outs of IT. While it may not be possible for you to hire an end user to work in your IT department, it is extremely important that you have clinical and financial staff actively involved in IT. You must also have a strong data person on your team. You will not survive in today's environment without the ability to access and analyze data quickly. Is your electronic record customizable, or do you have to wait for your software company to make changes? We are fortunate to have a record that allows for customization and cannot imagine it any other way. The obvious advantages to customization is the ability to design our record, how we want it, when we want it, and not having to pay thousands upon thousands of dollars every time we need to make a change. As an agency, we've worked very hard to create a user-friendly, compliant product for our staff that meets the requirements of our funders and accrediting bodies. This is an ongoing process as requirements change and technology improves. Is your vendor keeping up with industry trends? Is your record certified, and is your software company keeping up with each phase of meaningful use? What about CQM, MACRA, and MIPS? Do you have access to dashboards? Do you have a visual health record? Can your staff look at one screen and know what is going on with their clients? How is your software company using mobile technology? We are working with our software company to push our software to the next level with the use of their mobile technology. We are currently in the process of redesigning our assessment to comply with some changes that are being made in the state of Illinois, and at the same time, we'll be rolling out a mobile assessment module. This will allow us to either send a secure link to clients to collect information prior to their assessment or give clients a tablet when they check in to complete information. We believe this will expedite our intake process and allow us to see more clients in open access. We are also working with our software company on a solution to add technology to our group sessions. Clinicians in our substance use programs often have well over 100 group notes to do on a daily basis. Currently, our clients complete a group closure sheet on paper, and this information is then typed into a progress note. Our goal is to provide a tablet for each client and group. Clients will use the tablet to enter group closure information, and this information will then be linked to a progress note. The hope is that clinicians will be able to take a few minutes following the group to finish up their notes and sign off on them, eliminating hours of daily paperwork. Finally, we are working with our software company on a solution to collect electronic client signatures for all home visits. We are currently obtaining client signatures on paper for home visits and manually tracking these in Excel. This process is an administrative nightmare and certainly not ideal. Home health has been obtaining e-signatures for years, and now with behavioral health care under the same scrutiny as home health, it is important that we implement this technology in our industry. Finally, are you developing your EHR with a purpose? At Heritage, everything we add to our record is very intentional and thought out. We have a council that makes decisions collectively on any changes or additions in our electronic record. ICON, as we call it, is comprised of IT staff, clinical staff, financial staff, and support staff. The team meets on a weekly basis, and all requests in the record must go through this committee. Every time we add a data field, we discuss the intent and make sure we have a clear definition of what it means. Is this required data by a funder, an accrediting body? Will it reduce risk, or is it something we simply think is important? Once it is determined that an addition or change will be made, we decide how it will be collected. Drop-downs, checkboxes, radio buttons, is it a number, a character, and so on. I can't stress enough the importance of understanding how the data is going to be used. Data cannot be aggregated if it is not set up and collected in the proper format. I tell this story all the time as an example of why collecting data properly is important. We live in Decatur, Illinois, and at one point we found over 40 variations of a 7-letter city. In this scenario, we were analyzing services provided by city. If we had not caught the spelling discrepancies, we would have missed any services that were provided to a client that had Decatur misspelled in their address. I could talk for hours about the importance of properly collecting data in order to analyze it. But we've got 6 screens that I want to just share with you, and most of those screens are more financial, but we have countless reports that we use to measure and audit our clinical data on a daily basis. The first report is billable hours. This report shows us by week for this fiscal year how many billable hours we had for any given week. So you can see dips on this report, and the dips really tell us, looking back, that was the week of Christmas, the week of Thanksgiving, but we can also see an upward trend at this point in the year. So that's what we want to see. This is actionable data, things that we can make a difference and do something about. The next report is individual staff weekly hours. This is looking at an individual staff, so this gets away from the old productivity reports, and it really is showing a staff person, how many hours they worked. So the way we look at productivity now is we exclude their vacation and everything, and we figure a percentage on the hours they were actually working. So in this case, the expected, when you see the week where it dips, she was on vacation that week. And then, so what you hope to see when you look at this report is the blue line is over the yellow line. So in this case, this particular staff person's productivity looks very good. This report shows our department, a department in our organization, and their total hours. So I didn't want to give all the reports of just the good things that's going on. You know, we look at data for a reason because we know we need to do something with it. If it was always good, we wouldn't need to look at it. So in this case, we have a department this is the department that Tim spoke of earlier, our outpatient team, and you can see this is by the year, and he spoke of last summer when we lost a lot of our staff. So you can see the gap last summer and where some of those challenges were. So the blue line is where they're at, and the yellow line is where they should be as a department. So we're closing that gap, and we're moving in the right direction. This report is a report that we review on a monthly basis just to look at our occupancy in our residential programs so we can see if we're keeping our beds full in our residential programs. So this group, I was just checking our time to make sure I still had enough time. These graphs show depict our groups. The top graph is just showing how many clients we had attend group in a given month. So one of our focuses has been group participation for clients in our methadone program. So So as you can see, we have definitely increased the number of clients that are attending group. We also track client hours, so how many client hours did we bill for in group? And then the bottom graph shows the average group size. So we added a number of groups this past fiscal year, and that's reflected in the group size. So with more groups, there's fewer people attending the group, in each group. The last graph is open access. Tim spoke earlier about open access and the number of clients we saw that were coming in suddenly. We almost doubled the number of people that were coming in on a daily basis, and that's just reflected in this graph that, yes, this is the case and we need to respond to this data. I want to talk a little bit about revenue cycle management, and then I will turn it over to Candy. Revenue cycle management starts the moment a client walks in the door and does not end until payments are applied to charges. It encompasses everything from collecting client information, obtaining authorizations, collecting copays, coding, documenting, submitting claims, working denials, and applying payments. In January 2014, Heritage began submitting Medicaid claims to 2 managed care companies. This change came with many challenges. While our billing department worked diligently to learn the ins and outs of managed care, they struggled with getting claims paid. Denials began to grow and cash began to decline due to our lack of experience and inability to manage denials. After many months of increasing denials and concerns about declining cash, something had to be done. We felt like we had 2 options: either hire more expert billing staff or outsource our billing. Heritage began researching our options in the spring of 2016 and considering the cost of outsourcing compared to hiring additional staff. Either way, it was going to cost us more money. After much consideration, the decision was made to outsource our billing. In July 2016, we outsourced all of our Medicaid, Medicare, commercial insurance, and some of our grant billing to a revenue cycle management company. We were fortunate that our electronic health record vendor also had an RCM division, and this is who we chose. After 10 months of outsourcing, the results are in. Did we make the right decision? I would say yes. I've lost a slide in here, so basically what this slide shows is that our monthly charges have remained the same over the past 10 months, and our average monthly collections have nearly doubled in the last 10 months. So we definitely have, it's been successful. We're glad we did it, and we expect to continue to see improvements. One of the things the RCM team has also done for us is they've actively worked to collect nearly $1 million in denials that we have from our managed care organizations. So we have already collected some of that and hope to collect a good chunk of that still. So I'm going to turn it over to Candy now. She's going to talk about the importance of building cash reserves, and then we will wrap things up and go to questions.
One of the issues important to the Heritage Board was developing a cash reserve in our operating account to weather the ups and the downs of the cash flow. In the early years of my tenure, we were basically grant-based. That meant that we got, as soon as the budget was signed by the state and the contracts were made, we would get 1/12 of the payment before the month started. So you always had money to pay your expenses that were coming up during that month. We'd always have a little bit of hesitancy in Illinois when they would not sign any contracts until September or October of the year. So you'd have to worry about the summer. At that point, we would count on a line of credit to get through the summer. As we were looking forward to moving to fee-for-service, we knew that that wouldn't work, that we were going to have to plan to have plan for bills to be submitted and for the claims to be approved and payments to come, and it could take up to 90 days for all that to happen. So we knew we needed to do something about our cash flow. That red line on the graph represents my threshold. The board didn't really want to go below that's $1 million. And this is also over a long period of time. So the part under there, I had the part before it hits $1 million. My threshold was more like $500,000 because we were smaller, and we had less fee-for-service contracts at that time. So at the point where we knew we were going to fee-for-service, we intentionally started trying to build our cash reserves in our operating account so that we would have enough cash to weather those ups and downs. More recently, we've moved to a managed care company, as Mary talked about, for a lot of our Medicaid, and that process took us a little bit longer. And then it also gave us the money to weather the cash reserves to weather the state not having a budget for almost 3 years. There were some of our grants that we weren't paid for almost 18 months. So we had enough so that we could keep our programming going so that we could still serve our clients. This next slide converts it to a days of cash at month end, and it's a shorter period of time. In 2015 was when we started with the managed care company, and then we had a slight decrease. And then as we started into fiscal year FY16 was when we quit getting paid for some of our state contracts. At the same time, we were struggling with getting the denials paid by the managed care company. The upward trend is when we switched to the RCM in order to get our bills paid, and also the state reimbursed us for some of our contracts. And now we're back in that holding pattern for our contracts, but our cash flow is more stable. At this point, we'll review go back to the screen that has Tim's questions on it, and we'll open it up for questions.
All righty. Thank you very much, Tim, Candace, and Mary. Once again, it was a really informative presentation. We've already had a number of questions coming in from our audience. However, we'd like to remind you that you can use the Q&A box below the slides to submit a question at any time here over the last 10 plus minutes or so that we have here until the top of the hour. First question that we had come in is in regards to interns. Are you limited in what interns can do? The member of our audience asking this question says that their HR department has stated that their interns cannot complete any tasks that are billable, even if clients are uninsured. So basically, there's nothing that they can do from a clinical standpoint. Do you have any sort of recommendations on what to do in that situation?
Yeah, this is Tim. I do know that every state appears to have different rules regarding this. In our particular state, the way we have done it is we have to credential those staff at what level of billing they would be eligible for. So in Illinois, our master's level folks and the ones that are considered QMHPs, and if they're licensed, they're able to bill services at a QMHP level. However, interns come in with bachelor's degrees. They don't yet have the master's degree, so we don't bill them at the QMHP level. We have a mental health professional level that accounts for individuals who have a bachelor's degree from the right, as long as it's in the right field, whether it's psychology, social work, various human service ones that the state accepts. So we're actually able to do that. So I would consider looking at whether or not the credentials under which they're billing will be looked at differently, and would they be eligible to bill services that are under a different credential. And that's kind of how we've addressed it. And I don't know, again, without knowing what each state does, but that's how we've addressed that. And I'll say, I guess we're fortunate that we're able to do that and to do that. Now, with that, we have all the same HR requirements. We have to have all the same documentation prepared for the state to show, in fact, that they're qualified and credentialed at the appropriate level. So when they audit us from a licensing standpoint, that we can pass those reviews. So anything else you want to add, guys? Okay. That's a good question, though.
All right. Okay. On the concept of grow your own, how do you prevent limited thinking when you grow your own? The audience member says they've seen growing their own, it's the same ideas and the same thing over and over again. We've always done it this way, et cetera, et cetera. How do you break out of that mindset and get a healthy flow of new ideas coming in?
I'm assuming Candy and Mary will jump in on this as well, but one of the things that I think is key to that is, again, hiring the right people with the right stuff, and also when you look at who you're bringing into leadership ranks and how we go about continuously expanding their view and visions of what's going on. The fact that we send people out for trainings is because we emphasize wanting to know what's going on, that we're not stuck in a rut, that this is the way we've always. Matter of fact, I mean, it's fundamental even with orientation training. You know, if something's not broken, you know, people say, well, why fix it? Well, for me, if it's not broken, what do we do to make it better? So it's a constant culture for us that we want to expand people's views, looking at things that can be improved and done differently. So I think it takes effort. I think it takes an emphasis for management to not accept that, and what's your commitment to investing in that staff to make sure they don't get into that groupthink and not changing what they've always been doing.
Okay, Mary and Candy, did you want to weigh in on that as well?
We occasionally do have the opportunity to hire from the outside at a leadership position, and that always helps us rethink who we are and how we do things and stuff like that. We also encourage the lower-level staff to question what's going on. So if you get a bachelor's level or entry-level staff in who's worked somewhere else, and they bring their knowledge of where they have been, we use that knowledge. We will, go ahead and welcome, them to question and not, we tell them don't do it just because if somebody says to you, that's why we've always done it, then still ask the question. So it's kind of a culture thing that we put out there.
Okay. I'd like to remind everybody you can still submit questions in the Q&A box below the slides. We're going to keep going with questions here for another couple minutes. So if you have your questions, go ahead and get those in here in the next couple of minutes. Next question that came in from our audience: what do you do if you answer no to the question about having an involved board or strong management team? The audience member says you can't fire the board and all of the management team, so what can you do?
There's always one person out there that's going to ask that really, really difficult question. I think the challenge, I'll speak to the board issue first. I think you may not have an overly active and involved board who's got all those qualities we talked about, but I think it's important, this really unfortunately falls heavily on the shoulders of the CEO and their skill set in bringing that board along, and then finding some key strategic folks that are on that board who are able to see things that way. And hopefully you don't have a board that's totally devoid of some of those folks that you need. And how can they then help shape that process within the board, especially when it comes time to replace existing members. Again, boards are different from state to state, and requirements from locale to locale are different. You have permanent board members. How many terms are they allowed to have? When is their opportunity to bring in new blood? So those become kind of strategically important. And over the years, we've had some board members that hopefully they're not listening to this call that could be termed a bit toxic, that were not serving with the motivation of what you would hope, that maybe it was a resume thing for them. They wanted to be on a board where they didn't contribute, or they could be divisive. And my observation, since I haven't been the CEO here, is that by being at those board meetings, we've been pretty lucky and fortunate to have really skilled CEOs that have been able to handle that and be effective with that despite that. It's just a whole lot easier when you've got a really high-functioning board who's got those qualities.
We have offered our board members the opportunity to go to some national conferences too and participate in Hill Day and some things like that have given them a background that helped them, work with us on where we were going, the direction we were taking. And I think that has been beneficial. The other thing is when we have a vacancy, not jumping right away on just, taking anyone. We kind of plan for what's the next strategy, what do we need in the next board member. So currently we have 3 vacancies in our board, and we're working to develop, the right person, just like with the staff, the board that will contribute the most.
All right. Back to the concept of the wrap-up meeting. Tim, can you just kind of give a quick clarification on who all should be involved in that? How many people should be attending? Just who all from the staff and whatnot should be attending that wrap-up meeting?
That's a good question. So, when we've talked about this before, we've actually done our entire presentation just on our wrap-up meeting. So one of the questions that will come up is that's a pretty expensive meeting. When you look at the fact that both myself and our chief clinical officer are there, we've got most of the clinical directors and program leaders from the services there, you could look at it from the standpoint that it's an expensive meeting. But to me, it's that return on investment. And what we're seeing is that you need those people there. But in addition to that, we've got people driving the reports, we've got the IT people there, and we've got the key support staff leadership that's there. We do invite and we do encourage clinical staff who want to come, who have that time, to come and participate in that meeting. We want them to be involved in that process. So the vital people from how we set ours up was clearly the clinical leadership, support leadership, and IT folks. After that, the more you can get people involved, the better. One of the things that we're able to do that really has improved leadership's perspective and understanding of funder sources alone has been part of that meeting, knowing how getting authorizations and how all those dynamics work. That was not something that was typically the knowledge base of all of our program clinical leaders and staff. They're all seeing that now, understanding why authorizations and reauthorizations and how that impacts people who've been in a program, and all of a sudden you're risking not getting paid. That's tremendously helped us. So that can only help the clinical staff that are in the trenches doing the day-to-day stuff to get a better understanding of how the organization works and what is the data we need to be looking at and that we do look at in making decisions and why we're doing that. And that's been very, very positive. Anything else, Mary, you want to add?
I think I would just add that our wrap-up team has evolved. It started out with just 3 or 4 of us in the room meeting to talk about our open access and the problems that we were having on a daily basis. Was everyone seeing? If they weren't, why they weren't? And we saw the value in that process, and it's grown from there to a end-of-the-day meeting that staff actually look forward to coming to. It's not something that they feel like they're being made to be there. They come, they get information they need and answers they need to questions.
All right, I think we're going to have time to sneak in one more question here, and that is, are there special staffing requirements in order to accept Medicaid for opioid treatment?
No. So with opioid treatment, particularly with methadone, I can speak with more authority on that. Suboxone's a lot more simplistic, as long as you've got a waiver physician who's prescribing it. But with methadone opioid, you're not only dealing with your single state agency for addiction. We've got a methadone person for the state of Illinois under the division that covers that. But you're also heavily involved with federal government issues. We've got the DEA that comes unannounced on a periodic basis and they make sure you know they're present. You've got to cross your T's and dot your I's, so there's a lot of real significant compliance issues. But for the actual dispensing, our nurses have to be licensed in the state. That's the DEA's main concern, that they are licensed. We have to have a power of attorney for each of those people that work in there, and that gives me authorizing them so they can actually receive the shipments of the methadone. The clinicians who provide the addiction counseling services just have to meet our state licensing requirements. So they have to either be a certified alcohol and drug counselor or be a licensed counselor or social worker. So special ones for that, no. And really the challenge is really just getting a program like that started. There's just so much from a regulation and facility standpoint that you have to do.
Alrighty, I think that's going to be a good note for us to wrap up on. It's going to be all the time we have for questions today. I want to thank Candace Clevenger, Tim Mackin, and Mary McClyman once again for an excellent presentation. I also want to thank our sponsor, Echo Group, for making today's program possible. And finally, a big thank you to those of you in our audience for participating today. We hope you'll join us in the future for another Behavioral Healthcare Executive webinar. This concludes today's presentation. Have a great day.